So NIAGARA is designed, randomized phase 3 study, randomized patients with clinically localized muscle-invasive bladder cancer to receive 4 cycles of gemcitabine cisplatin plus durvalumab, followed by cystectomy, followed by adjuvant durvalumab for an additional 8 cycles, versus neoadjuvant gemcitabine cisplatin alone, followed by cystectomy without any planned adjuvant treatment. One of the primary endpoints of this study was pathological complete response rate. And the pCR rate was about 10% higher in the durvalumab arm versus the comparator arm. So the question arises, what are the implications of having a pCR on long-term outcomes? And so there are really 2 key findings from this analysis. One is that in patients who had a pCR, there was a benefit with durvalumab versus the comparator arm, which in retrospect sort of makes sense based on what we know about these treatments, but was somewhat surprising. Many individuals had thought that if you have a pCR, then patients do great and you wouldn't derive additional benefit from a combination treatment. And that doesn't look like that's the case based on the survival curves. And then also of note, in patients who don't have a pCR, there's a benefit to receiving perioperative durvalumab. And this also makes sense. We know that some patients probably have downstaging of their tumor, potentially eradication of micrometastatic disease and downstaging of their tumor, but not complete eradication of the primary tumor. And they're still benefiting from treatment, but not meeting that definition for a pCR. And so those were the 2 key findings. In both patients who have a pCR and patients who don't have a pCR, there seems to be benefit from adding perioperative durvalumab. In the post-surgery setting, durvalumab, similar to adjuvant nivolumab, it's a treatment that in the context of treatments, in the context of systemic treatments that we could administer in a post-cystectomy setting, it's a class of drugs that overall, for the majority of patients, is fairly well tolerated. And it's a drug that doesn't have dose-limiting side effects in the absence of developing an immune-related side effect per se, that one can deliver that 8 months or 12 months of treatment, depending on whether or not it's part of the perioperative regimen or the adjuvant regimen. What we don't know from this study, though, is the contribution of the adjuvant portion versus the neoadjuvant portion with immune checkpoint blockade to the improvement in outcomes. So patients who had a pCR do better with perioperative durvalumab. Patients who don't have a pCR do better with perioperative durvalumab. But based on the design of the study, it's impossible to tease out if that benefit is being driven by the neoadjuvant part, the adjuvant part, or whether or not both are contributing. Several additional analyses planned, from translational endpoints to quality of life endpoints to more surgical related endpoints. In terms of teasing out the contribution of the neoadjuvant and adjuvant portion, really the only way to do that is to do a study that had that extra arm, just the neoadjuvant part without the adjuvant part. Whether or not we'll see that, that's hard to say. These are very large studies. I think we need to remember that when these studies were designed, we had come after a decade of about 20 years where it was actually difficult to finish an adjuvant study in bladder cancer, to complete accrual, multiple failed trials because of poor accrual. And so to think about design, and this is a 1,000 patient plus study, so to think about adding another arm at the time and really having that study complete enrollment was a daunting task at the time. I think in retrospect, what we've seen is that we can complete studies in the perioperative setting in bladder cancer these days. And I think that speaks to designing studies in the future that can build on these results.